All right, so we're going to continue on with immunizations. Does anyone have any questions about toxicology or any other things we've covered? Anyone get any up close and personal with maybe a snake or two while you're out egg hunting for Easter? Nothing? Okay.
Actually, we did.
Yeah?
Yeah, we saw a black snake over at the sunfall when we were walking through.
Did you like try to look for the identifying
I was trying
markers?
to, my fiance ran away, so like he's...
Okay. That is quite reasonable. Wait, I gotta look at the subcaudal plates. No, don't go. Yeah. Okay. I understand. Yes. Okay, so we're going to talk about vaccinations today, and so you guys have covered this previously in PEDS, correct? Okay, so I'm not going to make you guys memorize the entire schedule.
Thank you. You beautiful person.
I mean, honestly, like, what do you do in the real world? Look it up. I mean, a lot of, like, especially if you work, like, in a PEDS office or somewhere, like, you're going to have it on the wall, and so I even see a lot of providers, like, you know, you get into a habit or a routine that, you know, if you're doing a lot of, like, you know, the first couple of months of, you know, visits for an infant, like you get used to it. You know what they're going to be getting, you know, from visit to visit. But a lot of cases, if it's not your routine thing, you're going to look it up on the wall anyway. And stuff changes every single year. So I have to update this lecture every single year because there's a new schedule out. Do you guys know when it comes out?
Before school?
Every January actually it comes out. So that's why I can update these pretty routinely because, you know, the 2017 ones are already out. And so they come from CDC, absolutely. So that's your disease prevention group. Anyway, so history of vaccines is actually kind of gross when you look at it. But people were basically inoculating themselves with the pus of people who had smallpox, and they realized, hey, we didn't get smallpox. That's kind of cool, right? Not really, it's kind of gross. But anyway, so then other things that we're kind of noticing, like, you know, these milkmaids who had contact with cows with cowpox, they ended up not getting smallpox, right? So there's some degree of homology there. They were able to have some cross-reactivity and not actually have immunity against the disease itself. But since then, we've had lots of generation of different types of vaccines, lots of different things, both against bacteria, both against viruses, and also against actual some of the toxins specifically that you can have being produced by things like the bacteria, right? So lots of different varieties. Do we get vaccinated against all of these things? Monkeypox, perhaps? Not usually, right? So some of these are going to they'll be situational. Some of them are going to be based on travel. So if I'm going to certain countries, they'll say, hey, you should probably get, you know, vaccinated against these things versus what you get, you know, just routinely. Or if you are in a high risk type of situation, like, you know, if you handle a lot of, you know, if you're in animal control, like, you should probably get, you know, vaccinated against rabies and things like that. But that's not a normal thing that a lot of people get vaccinated against, just on a routine basis. But we'll kind of look at those different schedules and some of the things that are more common. So just an example to show the effects of vaccinations. You can see here how as the rates of vaccination for polio started to increase back in the 80s, you saw that there's a big reduction in actual incidents, new incident cases of polio that were generating there. And so, you know, this is really, really important that people stay vaccinated, because what happens when you have people that start to not be vaccinated? You can have outbreaks, absolutely. So there's a really good case of this that occurred. I'll show you an example in just a second. But what are some reasons that people may not get vaccinated? And you'll hear lots of different things, probably a lot more than what you'll hear in this list. Yeah. So when I think of reputable people who've done lots of good research on a topic, scientific mind, if you will, I think Jenny McCarthy. It's like, wasn't she getting singled out, like, back in, like, I remember watching on MTV, like, most of you guys are too young for that, so. Anywho, yeah, so there's lots of different reasons. So Jenny McCarthy might be a big one. Concerned about vaccine adverse events. So what are some, like, some adverse events you think you would hear from someone who doesn't get vaccinated? Guillain-Barré, yeah, that can be a big one. Autism can be another big one. How about, like, every time I have people that don't want to get the flu vaccine, they say, well, I'm just going to get the flu. Like, every time I got the vaccine, I get the flu anyway, right? So that would be a common one you hear, because, and we'll look at the flu vaccine and why that's actually the case. Like, you can get vaccinated every single year and you can still get the flu, right? Because there's lots of different strains that are out there. In a lot of cases, we're just doing a guessing game and trying to predict what the most common strains are going to be. And so you're going to see that we're not super great at that every single year. So adverse events can certainly be a big thing. If they feel like they have insufficient time or inconvenience, like, you know, you take it for granted being like in the healthcare profession, like, you know, they're constantly hounding you to get your flu vaccine, if you need to get your tetanus booster, if you need to get these different things, like, you're kind of forced to by work in a lot of cases. But if you were not in the healthcare field, you may not think you have time or you know, be able to get that done. Here in Florida, it's become more convenient. Do you guys know why? Yeah, so pharmacists have been able to vaccinate for a few years. Like when I was in school, from say like 2006 to 10, that was like the new thing. So we were actually starting to get trained on how to give vaccines like my last year of school, and so it's become more and more common because we've started to kind of expand out what we could give. So initially we could just get the flu vaccine, but then it's kind of like pneumococcal. I think we can give like Tdaps now, things like that. Obviously, I'm not in the retail world, so I don't get a lot of exposure to that. But that is one thing that's kind of helped increase the convenience, just because it's out there. You know, you can go to CVS, Walgreens, and get it done. I have kind of a funny story about when we were trained on how to do vaccines. Like, you know, in pharmacy school, you don't get a lot of like practical hands-on skills necessarily. You know, learn how to do a blood pressure and, you know, take a pulse and things like that. But we were giving IM injections to one another. And so I had a girlfriend in school at the time. And so they're like, okay, well, if you go too deep and you hit the bone, just don't say anything. I don't. So I was like, okay, that sounds easy enough. She was kind of skinny at the time, so I didn't like knocking her. Totally hit bone. I was like it felt super gross. And she was like, what happened? I'm like, nothing. And you took it out. No one passed out, fortunately. But that's usually why they don't let pharmacists actually do stuff. Yeah. So anyway, so that's one big thing, is just convenience has become a lot much more convenient. Some people rely just on naturalistic kind of medications, thinking homeopathic things will be able to keep them healthy. Some people just like to avoid all medications in general. Needle fear can be a big thing. What are some ways we've kind of overcome fear of needles in some cases? Yeah, flu mist. We have intranasal administration, so that's kind of helpful. So if someone is really needle phobic, that could be one potential avenue they can go down.
Do they still use those needleless things that bruise your arm?
I don't know if they still use those or not. I know that is one potential method. Usually use like compressed nitrogen gas or something to enable to force the drug through the skin. So it's kind of a high pressure thing. I'm not sure if they still do that anymore.
In the military, like you'll walk down a gauntlet and they'll just.
There you go. Yeah. So I guess in some cases they will still use that. Yeah. But that is one potential method for getting drug into the body, which we don't use very commonly. But and then there's also this kind of perception of kind of low personal risk for infection. So you know, if we've got the herd immunity, if everyone else is vaccinated and I'm not, I'm going to be okay because, you know, no one else around me is going to have it. But that can be a problem because as fewer and fewer people get vaccinated, then you run the risk of having outbreaks of disease that can occur. And actually, my wife was listening to, I think, NPR or something the other day, and they're talking about the measles rates. Is actually the number of people vaccinated against measles has been going down pretty steadily. I think we're around 10% unvaccinated, and they're saying that around 12% or so is really where you hit the case where you can have a potential epidemic that could occur there. So I'm not sure the veracity of all that reporting, but it's certainly a thing that you could see as vaccination rates go down. So one good example of this was in Japan back in the 70s. They had a very successful pertussis vaccination program, and about 80% of Japanese children ended up being vaccinated. And so they have relatively few cases across the entire country, no deaths on pertussis. And so this is actually becoming a big deal here in the U.S. as well. That's why they also recommend a lot of pregnant ladies get their Tdaps and whatnot in order to prevent pertussis. Anyway, so at one point they said, hey, you know, guess what? There's no longer any risk here. We're going to go ahead and stop vaccination. And so then by 76, they had about 10% of infants getting vaccinated. And then they end up seeing some deaths associated with that, lots of cases of pertussis kind of building back up. So they finally said, okay, we should probably just keep vaccinating forever. And so that's kind of where they've been seeing the kind of residual drop kind of being pretty consistent there. So this is why we should continue immunizing. Obviously, some things like smallpox, you know, you say like, okay, that's been eradicated, so you may not see, you know, common vaccination against that. But of course, you know, there could be cases where they could pop back up potentially. So we know vaccines help to prevent lots of different types of diseases. Obviously, things like the pneumococcal vaccine, especially for older patients. Vaccines for some of our immunocompromised patients as well can be very, very useful. We'll talk about some of the caveats with that one. But in general, you're going to see decreased number of people dying to these preventable diseases in the long run. Also, decreased hospitalizations, a decreased cost. All these things are very good. And if you look at the actual dollar amount to vaccinate somebody versus the amount of money you end up saving, it's one of the best kind of bang for your buck kind of health interventions that you can actually make, besides like getting someone to stop smoking or something like this. This is usually a money saving kind of thing. So what are the different forms of immunity that we have? We have passive immunity. So can anyone describe passive immunity?
GA from mother's breast milk.
Okay, so that's a really good example. So you have immune globulin from the mom that's being transferred via the breast milk. So that could be a good one. So what's the kind of the key thing about passive immunity?
Your body doesn't make it.
Yeah, your body's not making it itself, right? So your body doesn't have really the ability to mount its own defense, right? So temporary is the big thing here. So this is really just a temporary defense. And so actually the mother transferring immune globulin over to the baby is actually going to be important, because that'll actually determine how we immunize some of our infants, and we'll talk about that a little bit later. But again, this is nice because it provides immediate protection. So you're going to see, especially with a lot of like our gained immunity or things like inactivated vaccines and things like that, it takes time. We end up needing several different doses in order to be able to mount a good defense against this. But passive immunity provides really just immediate protection, but it's going to be temporary. So it may last several weeks, may last several months, but again, it's going to go away at some point. So again, if we were to give immune sera, we could either give it naturally through, say, the mother's transfer, like we mentioned, or you could do things like giving immune globulin. So that can be a very common thing you'll see for lots of different disease states. Actually, immune globulin is one of those things where if you're not sure how to treat a patient, you've kind of tried everything else, just give them IgG. That'll probably fix it, right? So lots of autoimmune conditions, lots of different things we'll try IgG for. We'll talk about that later. But basically, that is a way to provide some immediate passive immunity. And then you can also have antitoxins. So we just talked about this very specifically back when we're talking about snake bites, right? So if a snake bites you, we give you the antivenom that is specifically immunized against that venom. But you're not going to be able to, be immune to any snake bite after that, right? Because you're not producing your antibodies. Now, I've had people who have tried to get themselves to have active immunity against snake bites by injecting themselves like very small doses subcutaneously over time. I would not recommend that. It sounds like a very bad idea, but that is something people may try. So, and then active immunity is just something that the person's mounting themselves. Usually has delayed protection as your body starts to develop these antibodies against that specific antigen. The durability is going to be a whole lot longer. So instead of weeks to months, you can have potentially lifelong immunity, or things that last for several years. And so you can either develop this from just natural disease on its own or from vaccines. So how can we predict how someone is going to respond to the vaccine? Because this is very important to make sure, based on your patient population, kind of who you're dealing with, what their comorbidities are, they may or may not be able to mount a really good response in order to develop this kind of active immunity. So some things we can look at with the vaccine itself. So we have the viability of the antigen. So do you guys know the difference between a live attenuated versus an inactivated vaccine? What's live attenuated mean? Kind of like a wimpy form of the bacteria, right? Because again, if your patients are asking you like, well, what's the difference between vaccines? Like, you want to think of like, good like lay people ways you can explain it to them. So I always try to think of like, what's the easiest way I can explain this to someone if they were to ask me that knew nothing about medicine. I say, well, this is kind of a wimpy bacteria that your body is going to be able to fight off pretty easily. Going to be able to develop that immunity, but it's not really strong enough to cause disease in and of itself in most patients. We'll find there's some exceptions to that. And then the inactivated, we'll cover some examples of those, but usually it's either just a portion of the bacteria or the virus, or it is a killed off version, right? So it's just a version that is already dead. It's not really able to cause disease on its own. And which one do you think would provide the more active immunity? Yeah, the live is always going to be better, right? Because that's more closely mimicking the actual disease process, right? So your body can mount a more kind of natural defense against that, and it's going to be able to remember that for a lot longer. The dose of the antigen given is going to matter. So larger doses, or we've already kind of taken that into account when you look at your dosing strategies there in the schedules. But this is why you need sometimes repeated doses in order to help kind of give a continual or repeated dose in order for your body to respond to that and help kind of select out and produce more antibodies for that. We'll also look at things like the type of vaccine. So you can have ones that are polysaccharide, which are basically just kind of a long chain of sugars that the antigen is bound to, versus some that are protein polysaccharide based vaccines. You're going to find that there's a little bit of difference in how your immune system responds to this, and that's going to dictate how well someone like an infant is going to be able to respond to that. So we'll go over that in more detail in just a minute. But something like the protein polysaccharide is going to be better for infants who have kind of a poor, underdeveloped immune system versus just the polysaccharide. And then also the route of administration can be important. We've found that by giving injections in the gluteal area, it can have less consistent responses than you would see if you were to give it in the deltoid, or if you give it in the lateral aspect of the thigh or something like that. Really just the gluteal and administration has been pretty much kind of gone by the wayside for the most part, unless you had no other area. So also looking at host factors. So how do you think age would play into response to a vaccine?
Infants can't not respond.
Yeah, infants have underdeveloped immune systems, so they're not really able to mount a good response. What about on the other end? Yeah, as you get older, potentially if you have more comorbid conditions, you may not be able to mount a good response either because your immune system is weakened for lots of different reasons. Presence of the maternal antibody, how do you think this would affect a response to a vaccine? Increase it or decrease it? Decrease it, why? Yeah, so it's like, yeah, so you can't really mount a response to something if I already have these immune globulins that are floating around binding it up, right? So if mom's antibodies are already taking it out, the baby can't really mount any kind of response to that. So that's why one of the reasons why we actually save some of our vaccines until the 12-month mark when a lot of those IgG levels have gone down, or IgA levels have gone down for those patients, right? So you're going to see that why the 12-month mark is usually where you see like your MMRs and things like that get started. So that interval between immunizations, if you do not give a long enough time period, usually you're going to see that the minimum interval is usually about 4 weeks or so. If you do not give it enough time for the system to kind of reset itself and able to mount another response, you may see you don't get as good of a durable response. The timing is going to be important there. And then also coexisting disease. So if you're already sick from something else, you may not be able to mount a really good response against whatever vaccine you're administering. And so you'll see that concomitant illness is going to be kind of a precaution against giving a vaccine during that time frame, right? So if everybody's kind of busy fighting off something else, it's going to have a hard time kind of shifting focus and focusing on that vaccine. Okay, so we mentioned a couple of different types of vaccines that are out there. So the live attenuated, again, these are cultivated. They've been kind of altered to disable their virulence, but the response is pretty similar to the actual illness itself. Who would be at risk for an adverse, actually getting the disease if you were to give a live attenuated? Yeah, so they're not able, so like your HIV patients, your patients who are getting active chemotherapy, who are neutropenic, patients like that who are not able to mount a good immune response, they are potentially at risk for developing active infection from these live viruses or live vaccines. So that's one of those things that you want to be careful of and make sure you're not administering to those patients. Killed or inactivated is either the whole organism that's been killed or just a piece of it. These are going to require a repeat dosing. Okay, so you're going to see, if you have like a one-time vaccine, for the most part, that's going to be a live one. There's some exceptions to that, but for the most part, for inactivated or killed, you're going to have repeat dosing for those. Some of them can be kind of a subcategory of killed or inactivated as the fractional. So these are typically protein-based. You can have toxoids that are inactive toxic components from the microorganism. So can you guys think of any examples of that? Tetanus is a good one. Yep. So we have like tetanus toxoid that we'll be giving in order to actually mount a response not to the bacteria itself that's producing the tetanus, but the actual toxin. You guys think of any other ones?
Diphtheria?
I'm not sure if diphtheria is a toxoid or not. I don't believe so. But I think like we'll look at some of the immune globulins that we can actually administer to be eating stable. Those are not really providing active immunity, but you'll see that we have other products that are targeting in specific types of toxins that are out there. You have subunit ones that are based on just affecting a fragment, either the attenuated or inactive organism, and then the polysaccharide base. So you can see these conjugate ones where basically we're just attaching a piece of the organism to either some kind of sugar molecule or a protein sugar based molecule. So those are going to be things like your pneumococcal vaccine are going to be in that list. So I'll show you a table giving some more examples. What do you think a recombinant vaccine is?
They've used other things to use the DNA to sort of make a similar model.
Yeah, so we're basically kind of engineering things like yeast or things like bacteria in order to help produce things that we can make vaccines out of. So for instance, like yeast produce a recombinant flu vaccine, right? It's one we don't use very often, but we'll talk about situations where that can be useful. That could be one example. And then obviously the immune sera, this provides that passive immunity. Is where we get the IgG for it. So think about things like botulism immune globulin, think about tetanus immune globulin, but you can just give pooled IgG that is able to have antibodies against lots of different types of diseases. So we'll look at that a little bit later as well. Again, that one's only providing passive immunity. So other components, it's important to remember that you don't just have whatever the body's mounting a response against. There's lots of other active or inactive ingredients that are going to be included there, and it's important to consider those, especially when you're dealing with things like allergic reactions or adverse effects. It could be related back to one of these products. So obviously you're going to have things like water, saline, even albumin can sometimes be used as a vehicle for some of these vaccines. But there's lots of preservatives, stabilizers, and antibiotics to help to maintain those integrity of the vaccines that have a longer shelf life. We can use them for a longer period of time. This is where you get that thimerosal, which is the mercury-based preservative that people are really worried about causing autism, right? So that was one of the big ones. They're worried about mercury acting as kind of a neurotoxin linked to autism. So again, patients may have allergic reactions. Keep in mind that just because they have an allergic reaction to one brand of it does not mean they're going to have an allergic reaction to all brands of that, right? Because you can have different manufacturers producing products a little bit differently, using different adjuvants that they may not have a reaction to. So just be aware of that. Okay, so again, we mentioned live vaccines. So these are weakened versions of either the wild virus or the bacteria. They have to replicate to be effective. So again, this is why you don't want to give it to a patient who has active, maternal immune globulin floating around, because it's going to be able to knock it out pretty quickly and not really give the chance for it to replicate and the body to mount a response to it. Again, you can find that most of these end up having just a single dose, because you can have a pretty sustained good immunologic memory to these for the most part. They tend to be a little bit more unstable, so their shelf life is not super great. Storage conditions for these tend to be really important. How do you think most vaccines are stored? Yeah, they have to be in the fridge, right? So that's one of the things that can be problematic, especially if you're thinking about treatment for patients outside of here we have refrigeration everywhere. It's not a problem, but if you think about like third world countries and things like that, refrigeration may be something that's not super common. So that could be one problem with getting vaccine programs out to people in kind of more rural or kind of engineering kind of areas. But they will also interfere with circulating antibodies potentially. So again, if you're having an active infection that you're trying to fight off, you may not be able to really mount a good response to these as well. And you can have some severe reactions that are possible. So especially with patients who are immunocompromised already, they may develop active disease for those patients. So we do recommend not giving them in immunocompromised patients, pregnant women, and also infants. Okay, infants mainly because they're not really going to have a good response to it because of the maternal immune globulin. So some examples would be our MMR, which is why we don't give it to children until about the year mark. I only know that, or I'm cognizant of it because of the fact that my child's about to hit her year visit, and so she's going to be in a whole lot of pain after that. I can tell. Things like the influenza, specifically the intranasal, you're going to find that the intramuscular is a different formation. It's actually live inactivated versus the intranasal, which is the live attenuated version. Rotavirus. You guys know how we give rotavirus? Yeah, that one's an oral version. We have other ones like BCG, which is a vaccine against what? Yeah, tuberculosis, right? So that's why you always want to ask patients whenever you do a PPD, have they had the BCG vaccine before? Because why do you ask them that? Yeah, they end up having a positive PPD. So we had one, I remember one guy in pharmacy school, we ended up probably getting a dozen different PPDs probably during that 4 years. One guy who was always testing positive, he had to go for chest x-rays every single time because of the fact that he was, he would always show positive because he had BCG, because he'd been born in another country where they give that routinely. Here, obviously, they don't, so we don't have a lot of false positives from that standpoint. And then oral typhoid would be another good example of a bacterial live vaccine. So again, the killed or inactivated forms, they do not replicate, they do not cause disease for these patients, and so you're going to have kind of less of a durable response, which is why we need to give repeated dosing for these patients, usually larger total doses than you would see with the live vaccine. Usually you're going to find that you'll have a kind of a temporary humoral immunity that will be, which is why we need to give 3 to 5 doses to kind of keep re-challenging the immune system to mount that good response. You usually have kind of a protective response after around the 2nd or 3rd dose. Okay, so after that point, you probably have some innate protection against the pathogen, but those kind of follow-up doses are going to really help to secure that, make sure you have a good memory of that the next time it shows up. This is why we use booster doses, because you're going to have those antibody titers go down over time. A very common booster that we give is?
Tetanus.
Yeah, so tetanus is one of the big ones, right? So that's why you always ask your patients, they come with a big wound. Have you had your tetanus within the past 5-10 years? If not, usually they don't know. You should go ahead and give them another one anyway, because again, it's going to help to bolster that immune response. You're going to have a higher antibody titer. It's going to be a good one. Sometimes like Hep B, like if you go into a healthcare environment, because we're in a higher risk kind of area, like they'll check your Hep B titers. So I ended up having a booster for that not 2 or 3 years ago at Nemours. So Lots of different things you'll run into, but that's why those boosters are needed. Some examples, so like a whole cell kind of variety, you can have things, viruses, so influenza, that version, then anything that started, things are no longer available in the US, but they've been historically available. Hepatitis A, rabies, as far as bacterial goes, whole cell would be like things like pertussis, typhoid, cholera, and then you can have some fractional varieties, which are again just a portion of the virus or the bacteria. So things like Hep B, the influenza that we use more commonly for intramuscular injection will fall into that list, etc. I guess, yeah, so diphtheria would be a toxoid that we're given for that one. Yep, had it on the slide the whole time. Okay, so then going into the polysaccharide vaccine, so again, you can have a pure polysaccharide, which is just the kind of the sugar chain that's there, so it'll be attached. Basically, polysaccharides found on the external capsule of the bacteria. These are going to be T-cell independent antigens. So because of that fact, you don't really get as good of an immune response as you would see with using a more T-cell dependent kind of response. So this is why if you give it to children less than 2 years of age, you don't really see as good of a response, right? Because you don't have that, you're using this T-cell independent kind of pathway. Also, you find that repeat doses don't really have a good booster response for that. But good examples of just a polysaccharide vaccine include things like pneumococcal, meningococcal, etc. The conjugate polysaccharide is what we normally end up giving to infants because it is going to be that polysaccharide plus a protein that's a little bit more reactive, and so it's going to be involving more of your T cells and also getting the B cells involved there, and it increases that kind of immunogenicity of it. So this is why we give like the HIV or Haemophilus influenza B vaccine to kids as very early on because they're able to mount a good response to that. And then there are some recombinant vaccines. Basically, we're going to have insertion of a viral gene segment into the gene of yeast, usually, is what we end up using most commonly. And so this will help to produce kind of just pure antigen based on that. So you have examples of like the Hep B vaccine, HPV vaccine, or Gardasil is going to be a big one. And then you can also have some live attenuated recombinant vaccines. So this is an example where they would actually be generating the whole virus. And so an example would be like the intranasal influenza is a good example of that. So as far as timing and spacing of vaccines go, it's important to keep this in mind. You don't want to give vaccines too soon. In general, you should probably err on the giving it too late rather than too soon in order to make sure those patients can mount a good enough response. In general, you can give all vaccines at the same time, right? So if you're coming in, you have 10 different vaccines, you can get them all. That's fine. But especially if you have 2 or more inactive vaccines, you can definitely give those either at the same time or any interval. It doesn't really matter if you give one day and give the next one the next day. It's not going to interact with one another. If you give an inactive and a live one, again, you can give them simultaneously or at any interval. The problem, though, is that if you give 2 live vaccines, because those are going to provide or generate more of an immunologic response, you need to wait at least 4 weeks if they're not given at the same time. I can give 2 live at the same time, not the 2 live crew, just 2 live at the same time. But if not, I need to separate them by 4 weeks. Okay, that'll give my time, the immune system to kind of ramp up to the first one, kind of recover, and then you can give the next live one that can have a response to that. Okay. So again, looking at multi-dose vaccine series, again, a lot of them are going to fall into this category. The minimum interval is going to be 4 weeks for that one, and then typically you're going to find that for the last few doses, usually the next to last and the last dose, tend to be about 5 to 6 months apart. And we'll look at the schedules and you kind of see how that kind of falls out. Again, that way we get a nice sustained immunologic response that's going to be very durable over the course of several years. By increasing that interval, you don't really see any diminished effectiveness, but again, giving it too soon is going to be a problem because you're not going to be able to mount as good of a response to that. So again, within a lot of cases, if you have a delay for immunization, so say you have like a 3-dose series, if you end up missing the last one, say like by a month, that's okay. You don't have to restart the whole series over again. If it's been several years and they did not finish up the course, then at that point you probably want to go ahead and just restart the series. So again, it's going to be on a case-by-case basis, but in general, you don't need to restart the series as long as it's kind of within reason. Okay, so immunosuppression is going to be a big no-no for live vaccines. Again, the patient might not be able to generate a good immune response to it to actually develop immunity, but also they can actually have active disease. And so in general, if a patient is going to be kind of temporarily immunocompromised, So say you have a cancer patient who you're going to be giving radiation or chemotherapy to, we would actually recommend you vaccinate either 2 weeks beforehand with a live vaccine or 3 months after radiation or chemotherapy. That way, you know, the immune system has enough time to kind of reconstitute itself. They're going to have a good response to it. Certainly, you can give inactivated vaccines during this time frame when they're getting chemo, but they may not be able to actually get a good durable response to that, right? So that's why I usually end up just recommending kind of them waiting until after they have recovered their immune system. And then looking at giving live vaccines and antibodies, do you guys know a situation where you give the antibody and the live vaccine at the same time? So sometimes for things like rabies, we might give like the immune globulin and the vaccine, get them started around the same time. So again, that can be important because you're giving them the active, if you're giving the vaccine and you're also giving the antibody at the same time, you expect them to kind of interact with one another. So this is why if you give the live vaccine first, you'll want to wait at least 2 weeks before giving the antibody. Okay, that way you have the antibody not going in and just kind of tearing up your vaccine, and then you don't have any good response to it. If it's less than 2 weeks, then you have to test for immunity or end up repeating the vaccine because it could be less effective. If you end up getting the antibody first, then you end up having to wait sometimes 3 months or longer for the vaccine to actually be effective in those cases. So it's not a super common occurrence you run into that. We'll look at some examples a little bit later. Okay, so this is a good table to kind of show you contraindications and precautions for vaccinating different patients, and if they've had previous reactions, if they have comorbidities, and it'll be divided into whether they have a live vaccine or inactivated vaccine you're trying to give them. C will be a contraindication, so do not vaccinate in those cases. P is a precaution where you may just want to be a little bit more careful for those situations, and then V says, okay, you're good to vaccinate, right? So if they've had an anaphylactic allergy to a component of the vaccine previously, they probably shouldn't get it, right? So what are some examples of common allergies you might run into with some of these vaccines? Eggs can be a big one with flu, especially. Protein. I don't think them specifically have any sulfonamides included in them. Latex is another big one. Latex is involved in the production of a lot of these vaccines, and so that can be a big thing. So if you have a very severe latex allergy, you would not want to necessarily give that. So again, it's on a case-by-case basis, so make sure you kind of look at that. They've had a previous case where they received a vaccine and developed encephalopathy. This is very rare, but if they had developed that, you would not want to continue giving more doses of that vaccine because that could occur again. For pregnancy, we don't want to give live vaccines because again, that can cause potentially active disease. You worry about that interfering with the fetus, but inactivated vaccines are okay to give, right? So for example, getting the flu vaccine while you're pregnant, as long as it is not the flu mist, which is a live attenuated, you want to give the intramuscular form. Okay, so you give that for pregnant patients. We routinely do the Tdap because you worry about pertussis, you know, in infants and whatnot. That's actually on the rise, so we definitely recommend vaccinating them. If they have immunosuppression, certainly you can give inactivated vaccine. They may just not have as good of a response, so you want to be kind of careful with that, depending on kind of how severely immunocompromised they are. But do not give live vaccines. I already mentioned that. And then if they're already having a severe illness, you may have some pause in giving either live or inactivated vaccines, because again, if they're fighting off some other infection, if it's just a cold, you're probably okay to vaccinate, right? But if they're having to deal with sepsis, maybe now's not the right time to vaccinate. I mean, you can probably wait a little bit, right? So let them deal with that infection first, and then once they're kind of on the mend, then you can give them one of these vaccines. And then recent blood products. Why do you think this would be a precaution to getting live vaccines if you've recently had blood products?
Maybe the people.
Yeah, so there may be antibodies in the blood products against what you may be trying to vaccinate against. So you may not see as good of a response to live vaccines, but inactivated, you're okay to go ahead and immunize against it. Because again, with the inactivated, you're usually giving repeated doses anyway. So by the time you give those repeated doses to re-challenge the immune system, the blood products are going to be mostly gone for the most part. So looking at some of the allergies that we can have reactions to. So eggs can be a big one for flu. So we'll talk about some strategies to get around that one. Yellow fever could be another big one. Latex for practically all of them is involved. Again, it's a very small amount of latex, so you need to kind of figure out how severe of a reaction your patient has had previously. But things like gelatin, neomycin, streptomycin, you see we include antibiotics in the products as kind of preservatives in order to make sure their stability is good for longer. And even things like aspirin. If you have a severe aspirin allergy, you'd want to avoid the live attenuated flu vaccine. So as far as administration goes for vaccines, there's lots of routes available, as we've kind of alluded to. You can give subcutaneously, intramuscularly, which is probably the lion's share of vaccines you're going to give are going to be intramuscular. Obviously, you can use oral for the rotavirus, and then intranasal occasionally for the live attenuated flu. As far as injection sites go, for IM, you want to make sure that you're using either the upper thigh, especially for infants and toddlers, but for most adults, you can go ahead and use the deltoid. For children and adults, they can both receive it there. Again, generally avoid injecting in the buttocks because you worry about having inadequate responses to that. I don't know if it's just an issue of erratic absorption or what it happens to be, but
The
the rubbing.
You're rubbing on the surface area, so it's a disrupting response to it.
Okay, there you go. So is due to the rubbing. So don't rub your butt if you happen to get injection there. Some cases you may need to use it, but it's very rare. So again, either the deltoid or the upper thigh if you need to for young children. It's nice when we can teach each other, right? Anyway, that or you guys are learning way more than this, and then I'm just wasting my time. So. Just kidding. So other adverse reactions that we can see with these vaccines, just local reactions are probably most common. So you can see pain, swelling, redness at the site of injection. You see this very commonly with the inactivated vaccines. Again, most of the time they're usually pretty limited, pretty mild for the most part. The systemic effects are usually what people complain about most frequently, especially after they receive the flu vaccine. They oftentimes complain they get the flu right after, right? Really, it's just kind of mild reaction that they're having to this. Obviously, they're not getting the actual flu. They'll be feeling much worse than that, so they should be lucky that they're only experiencing these mild effects here. But fever, malaise, headache, it's pretty non-specific, but just treat with some Tylenol, ibuprofen, whatever you need to kind of get through the fevers. It'll be pretty self-limited. And then rarely, patients with actual true blue allergic reactions, usually it's pretty rare. You can minimize it by doing do the appropriate screenings of finding out they have. That's why before you give any kind of vaccine, you have usually a pretty extensive questionnaire even beforehand to make sure they don't have allergies to egg or things like that. So if you do have, there are kind of government programs in place to look for things like adverse reactions to some of these vaccines, right? So this is kind of an important thing to make sure that we're reporting these as they occur. So the Vaccine Adverse Event Reporting System, or the VAERS, and so this is kind of nationwide. You call this number if you suspect that someone's had a true allergic reaction to any person, any age. That way they can kind of catalog these things. So for instance, if they were to put a new strain of the flu vaccine, because the flu vaccine comes out, a new one every single year, if they were to notice a new rash of, say, Guillain-Barré that were coming up, perhaps that is something that they can do a recall and pull all those doses back, right? So it's important that we report to those. Again, you can just look it up online and find the website pretty easily. And then there's a National Vaccine Injury Compensation Program, so it's kind of a no-fault kind of thing where if you feel like you've had a true blue reaction to this, you feel like you're entitled to some compensation, you call them up, and they, I've never actually had to interact with this program, but there's something out there for at least those people that feel they've had a true action, some sort of injury to the vaccine. So what's one of the most common things you're going to run into when you talk about vaccines with people? Some vaccine hysteria associated with it. I don't know if any of you guys are personally pro or anti-vaccine. That's fine, whatever you happen to be. But in reality, you're going to deal with people who are either getting vaccines or have been vaccinated. So it's important to be able to kind of talk to people who see a lot of this kind of stuff, especially on Facebook, things like that. Where you think like potassium chloride is a neurotoxin. Did you guys know that? Your body's riddled with neurotoxins right now. Have you know? But right, so you're going to see a lot of kind of misinterpretation of the data and whatnot out there that you'll see. So just be aware. Especially this came out when the H1N1 was a big deal. Back when swine flu was kind of first starting to hit. There's a lot of things out there. They rushed this vaccine out. It's going to give all these people Guillain-Barré, all this kind of stuff. So just be cognizant. It's important to be respectful to these people if they have their beliefs. That's totally okay. No one's holding the gun to their head to get them vaccinated. You can give them a stern talking to if you like, but be respectful. Concerning autism, though, there is some good information out there from the CDC saying that basically there's no clear link between vaccines that contain thimerosal and autism. This is probably one of the biggest kind of complaints that you'll run into is say, oh, I don't want vaccines, give my kid autism. There's really no good evidence out there to support that. So you may find individual tiny studies that show a link, but what do we learn in EpiBio? Right, you need lots and lots of people because small sample size means you can find. I can do a sample of you guys and probably find some kind of link between, introverted people and vaccines or whatever it happens to be. I would be the one driving most of that effect over there. But the big thing is that, when you actually combine a lot of these data together, you look at things like meta-analyses and whatnot, you're going to find that there's actually no good link to show that vaccines are going to cause autism, right? So again, point these people to the CDC. That can be some helpful information. Some people are still not going to be convinced, in which case, they're just kind of a lost cause. So briefly, we'll kind of look at some of the different immunization schedules, and then we'll talk about more specific vaccines, and then we'll kind of wrap this section up. But so again, the childhood vaccines that are commonly recommended, you can see a full list here. Obviously, I'm not going to have you memorize when they should be receiving all of these, but we'll talk about some of them a little bit more in detail. Notice that you have Tdap and DTaP. So when do we use DTaP versus Tdap?
Big D for the children.
Big D for the children, right? So it's usually less than 7 years of age. This took me forever to remember, just from working in the ER and having wounds and stuff. The kids need boosters and they have never been vaccinated before. And you have to get them started on something. Really, it just has to do with the dose of diphtheria that's in there. For younger kids, they need a larger dose of diphtheria to start that response. And so as they get older, they don't need as big of a dose. That's where the Tdap, the little d, is going to be used for the greater than 7 age group. But certain things like pneumococcal, HIV, a lot of these things have really decreased the incidence of a lot of these diseases that have occurred, especially like HIV. It used to be a very common cause for pneumonia. It's really kind of dropped off pretty significantly since we've recommended routine vaccination. I was actually doing some research, or updating my slides and whatnot. I found like HPV recommendations have changed. I'm not sure what year that specifically happened. We'll talk about that more in detail, about who should get HPV specifically. And again, the new schedule gets released every single year. So here's an example of what that list looks like. I'm sure you guys have seen this. It'll probably be in the walls in your offices at some point, where you can reference back to this. Notice that it'll give you the recommended kind of first point where they should be vaccinated. Notice things like your live vaccines, like your MMR, typically end up getting held off until about the 12-month mark. So you can kind of see that right here. I'll probably get the laser point out for the people watching the video. So you can see how some of your live ones end up getting pushed out to a month, or to 12 months, so that way maternal antibodies have kind of diminished to a point where the child can actually mount a good response to that, whereas certain things are going to be recommended very early on. So even at birth, you usually get your first hepatitis B dose right there. Okay. And then there's lots of catch-up schedules that are available as well to kind of help you out when patients who have maybe not been vaccinated previously, they need to kind of get them started again. And really the big thing is just to make sure that you're ensuring the appropriate minimal time between doses, right? Because if you do it too soon, you're not going to get as good of a durable response. Again, there's lots and lots of footnotes for all these different things. So if you ever go and look at the full kind of recommendations, you have a couple pages of charts, and you go down. There's lots of footnotes there. Each single vaccine talking about who should receive it when, what are the contraindications, precautions, etc. Here's an example of the catch-up schedule. So you can see here where it basically will give you just time between dose 1 and dose 2, dose 2 and 3, and etc. to make sure you're given enough time between doses. Notice here that for most of them that are multi-dose, you're going to find that you have either 6 to 12 months between usually the second to last, or kind of the final doses. You usually have about 6 months in between them. That way you kind of let the immune system kind of just chill for a while, and then you kind of give one more kick to the system to really make sure you're kind of selecting out for those good antibodies. And as far as adult immunization schedule, so obviously adults need fewer vaccines because hopefully they've received all of them as children. But in a lot of cases, that may not be what's actually occurred. But you'll find there's specific recommendations. A lot of these are going to be more situationally based in some cases. All adults obviously should be up to date on their tetanus. How often should we redo tetanus? Yeah, a maximum of 10 years. In some cases, especially if you're doing like wound care and things like that, if it's been more than 5 years, they'll go ahead and give you an update anyway. Usually we either use the TD, which is just the tetanus and diphtheria, or we'll just use the Tdap in order to get those boosters for those patients. MMR, varicella, and influenza. Obviously, influenza should be every year, absolutely. And again, as they get older, you'll find actually like the live attenuated vaccine that you can give intranasally is not recommended for patients greater than 50. Again, as they get older, that's just what it's marketed for. As they get older, as your immune system starts to become more compromised, you may not be able to mount as good of a response. So that's why they will only give IM only or the recombinant forms for those patients as they get older. 65 and older, they definitely should get updated on their pneumococcal. We'll find some patients should get that earlier based on some of their immunocompromised states. And then if you have, you'll have certain patients who are, say, in the healthcare field, they need certain vaccinations. Or if you are constantly in contact with animals who may have rabies, then you would have to get specific immunizations for that. And then travel is another big one. So if you have a lot of international travel, you may need specific vaccinations against diseases that are more endemic there.
Is there a Lyme vaccine, or are you prophylaxing with toxin?
I'm not sure what the current recommendation is if you necessarily need to give the vaccine or just prophylax. I don't know, maybe someone's done some recent travel and they can update us.
Can't prophylax. You're not able to prophylax for toxin.
Okay.
It doesn't work. Like they just say, if anything, if you get like a tick-borne illness, it'll delay the onset of symptoms. So.
Okay. There you go. Yeah. So maybe in that case, if, especially if it's really endemic in whatever area you're going to, just vaccinate beforehand. And, yeah. But again, you have to start to kind of think ahead, because it takes time for some of these vaccines to actually generate a good response. And so you don't want to like say, I'm going to Thailand tomorrow, hook me up. Like you may not really see a lot of use there. Okay. So anyway, so looking at, oh yes.
So we have a Lyme vaccine?
Yes, there is a Lyme vaccine.
Can I see that it's not available?
Is it probably not available in the U.S. You may see it being used. You may find it like in certain specialty areas. So like if you know you're going to be traveling to an endemic area, they may find special places where it's available. It's just not widely used here. Yep. Again, this is similar to chemo, where I don't deal with vaccines all the time, so there may be lots of stuff I don't know. Actually, there is a lot of stuff I don't know, so just take that with a grain of salt. Large grain of salt. So anyway, so here's the adult schedule. So you can see certain things they recommend. Obviously, influenza is going to be the biggest one. Just make sure you get that every single year. And why do we have a different influenza vaccine every year? Again, we're picking out different strains of the flu, because we know there's probably lots of thousands of different flu strains. And again, we're trying to predict what the most common ones are going to be. So again, we can't protect against every single type of form that's out there. So we have to kind of pick and kind of hedge our bets in a lot of cases. Again, looking at the TD or the Tdap, typically we will use Tdap at least once, and then TD can be used thereafter, but at least every 10 years you can update with that. MMR, you need it if you're going to be more kind of a high risk. So again, look at the footnotes, consult those, and get more into detail about some of that stuff. Other big ones, HPV tends to be for high risk individuals, especially. So for females, they will recommend up through, we'll talk more about that in detail, but they'll recommend up through 26. But actually for males, they'll say between 22 and 26 if they're really high risk for developing HPV. They recommend actually getting vaccinated there. So some of them are kind of recommendations. Some are like, you may think about it, but some of them are actually like, okay, you should definitely do this. So the purple is kind of more, a little bit softer recommendations there. Again, like notice things like the PPSV, which is that pneumococcal, that's going to be definitely recommended after 65 years of age to update them. Again, you'll find some patients may need that sooner, especially that ace-blending patients and things like that. Okay, any questions on the first half? All right, so we'll continue. So again, as I mentioned, there are specific cases with adults with different conditions where they may require different recommendations on their vaccinations, either new vaccinations you would not otherwise be recommended, or a different dosing or things like that. Can include pregnancy, up to HIV, especially the more immunodeficient HIV patients. They have a hard time getting good responses to a lot of things, but even other chronic conditions like alcoholism, COPD, etc. Asplenia can be another one that not really ever thought about before learning about vaccines for the first time. And then like things like kidney failure. A lot of dialysis patients tend to be more likely to developing lots of different types of infections, so they have different recommendations as well. And then obviously healthcare personnel, so you guys will have your own set of recommendations, since you will be kind of the public face to a lot of these patients, and they're going to bring all their cooties to you, so you want to make sure you can get avoid most of the bad ones. So kind of a little bit more complicated, but again, review the chart, look at the footnotes that are associated with this to get a better idea of like when should I be vaccinating these patients, specifically based on their comorbid conditions. So obviously influenza, we still recommend one dose annually. You may avoid the live attenuated version of the intranasal in some cases based on their immunocompromisation. Obviously Tdap, things like that, solid tetanus has the same kind of recommendations. You'll find that certain ones are going to be contraindicated. So you notice things like your MMR, your varicella, your HCV. Why do you think these are contraindicated in pregnancy and immunocompromised patients? Absolutely, yeah. So live vaccines, you want to avoid them in those patients. So again, the big red boxes, those are the biggest ones to obviously take note of. But you can see here all these other recommendations. So again, let's see, anything other special of note Right. So we'll talk more about in detail some of these vaccines in just a few minutes. But just be aware, if you have a patient with one of these chronic conditions, like just take a glance at it, see if there's anything that's recommended, make sure they're up to date. So, again, vaccinations in just special populations. So for infants, you do have that passive transfer of maternal antibodies during especially the third trimester, and then again during breastfeeding. So even if they are specifically just formula fed, they will still have some transfer that happened from the mom, and those will prevent a good response to live vaccines. So again, this is why we end up usually waiting until about 12 months, where the antibodies have degenerated to a point now where the patient can develop their own immune response. That's why we save MMR till 12 months. For premature infants, it doesn't really matter how premature they are. They're actually at even more risk than the term infants, but we're just going to be dosing them based off of their postnatal age, so they would get the same schedule as you see for a term infant. Okay, so no big differences there. They're getting the HIV at birth. They're going to be getting all the same stuff at the same time frames. For pregnant women, generally you're going to find that, especially for the either inactivated or attenuated vaccines, the benefits generally outweigh the risk for these patients. And currently there are no ascribed kind of adverse effects to the fetus based on a mother receiving a vaccine, right? So currently we don't have any data that supports that the baby's going to come out with a third head or anything like that, just based on receiving a vaccine, fortunately. We do recommend influenza for all pregnant women, or at least those looking to become pregnant during the influenza season. When does typically influenza kind of peak up? Yeah, it starts around October-ish, and then kind of starts to peak around the winter months, so usually January, February. We see those kind of peak months there. So if they're looking to become pregnant, and during that time frame, I would probably go ahead and recommend they get one anyway. They do recommend Tdap around the late second to third trimester, and that's mainly for the pertussis risk. So it doesn't matter if they'd had a booster for tetanus 3 years ago. Usually we'll go ahead and end up giving them another dose anyway. There's really not a big issue with giving vaccines more frequently. There's no adverse effects seen from doing that. In a lot of cases, you'll find close contacts for the infant also get vaccinated as well. So for instance, when my baby was born, I got vaccinated beforehand. Her grandma got vaccinated beforehand because she's going to be one of the primary caregivers as well. So that could be another thing you consider, making sure they all get. In fact, it's kind of funny. My wife, who she's also a pharmacist, she was very, very pregnant, going to get her Tdap from the pharmacy, and so she went to the pharmacist and said, "Hey, I'm here to get this." And even the pharmacist was like, "Are you sure you're supposed to be getting vaccines while you're pregnant?" So he obviously had not been up to date on all the recommendations, but said, "Yes, my OB-GYN recommended this." And actually had a lady behind her in line that said, "Oh, you're going to get vaccinated while you're pregnant?" So fortunately, my wife was much more tactful than. Unfortunately, I was not there because I probably would have had a few strong words to give to her. But fortunately, she's like, yeah, whatever. I got this. Give me the vaccine. Yeah. So, anywho, generally we avoid live vaccines. This is not any documented proof that there's any huge issues that will occur, but just weighing the risks and the benefits, may defer those until after the birth has occurred at that point. So generally, live is held off until after birth. So looking at those immunocompromised individuals, so this can include a wide range of people, so not just the ones we've already mentioned, but if they have a congenital immunodeficiency, they would certainly fall in this category. Those that have active leukemia, they're not usually able to mount a good response. They have a generalized malignancy. In some cases, they can be immunocompromised. But if they're receiving active chemotherapy, for sure, they would be considered immunocompromised. And then we also talk about those patients who are on chronic steroids. So they actually have recommendations based on the dose of prednisone or equivalent that the patients are getting that we consider to be immunocompromised. So prednisone doses stay greater than 20 milligrams a day or greater than 2 mg per kilo per day for more than 14 days, right? So if they're on that big of a dose for that long of a period of time, or kind of an equivalent dose of dexamethasone, hydrocortisone, whatever happens to be, they would consider to be immunocompromised and still fall in that same category as you would see on that adult special population schedule. So if you had a patient who had very severe autoimmune disease, they're on very high doses of steroids, they would be considered immunocompromised. Okay. So steroids given topically, they don't count. If you were to be giving steroids via a multi-dose inhaler, right, for asthma, those don't count. If you were to get intra-articular steroids, those don't count as well. Those patients are still having a competent immune system. The steroids you're giving in those cases are localized enough in their effects, not really systemic. You don't really see any big effects systemically from that standpoint. So they're okay to still receive any vaccines, any live vaccines especially. And again, avoid live vaccines for these patients because you worry about activation of actual disease. And then the other thing is other vaccines may not elicit a full response. So you may actually see you give them the full course and they still don't have a good response even after that if you were to check titer levels. They may need additional kind of booster doses. And then for healthcare personnel, oh yes.
So we keep talking about how diabetics are immunocompromised to some degree.
Mm-hmm.
Does this play into this vaccine role at all?
They don't really fit into that same category as people who are getting like chemotherapy, but certainly they're more at risk for. You want to make sure those are the people like you're kind of hounding to get their flu shot. If they're over 65, you're hounding to get their pneumococcal disease, right? Because again, they're also when they get sick, they tend to get sicker than an otherwise healthy patient, right? So that's kind of the other big thing is that we can prevent those diseases. That's going to be better for the patient overall. But I would not consider them to be as immunocompromised as someone with a CD4 count of 2, right? Or someone who's actually receiving chemotherapy or something like that. We had one I remember one of my preceptors were in the surgical ICU, and a preceptor, we had a patient who had gotten into a car crash and had HIV at the same time, and so his CD4 count came back at 2, and my preceptor was like, where are the 2 cells at? Are they just like in the big toe or something? Like, I thought it was kind of funny. Anywho, so absolutely annual flu vaccine is recommended for these patients, for healthcare providers. You'll find that there's a couple different varieties. There's trivalent and quadrivalent, which we'll talk more about in detail. Do you guys know what the difference is between those?
How many strains?
Yeah, how many strains is going to be good again. So the trivalent obviously covers one less strain than the quadrivalent. Usually the quadrivalent accounts for one extra influenza B strain. Usually it's kind of that H1N1 type of strain that they're kind of looking for initially. That's kind of what prompted them to add that quadrivalent strain there. But for healthcare workers, again, they're going to be under the same recommendations as anyone else. So if they're over 50, don't use a live attenuated. We'll go into the detail on those recommendations later, but they can kind of receive any variety. As far as Hep B, they should, if they don't have, usually end up doing kind of serological titers. So say, for instance, you go and work in a new hospital, they will do a Hep B screening usually for you if you do not have high enough titer levels. If you've never been vaccinated before, they go ahead and start up a new series for you. And if you have been, then they give you a booster dose there. And then obviously your Tdap, they would end up giving you a booster, once every 10 years. But you may need you start up a new series if they've never been vaccinated previously. And if they have really direct contact, if they're less than 65 years of age, you can get them getting a one-time dose of the Tdap instead of using just the TD. Okay, looking at varicella. So if the patient has no, again, still healthcare personnel, no serological proof of immunity, you can provide vaccination. Or if they have a history of disease, obviously they're going to have their own kind of innate immunity to it. Here you end up giving, say, 2 doses and it being 4 weeks apart. Again, 4 weeks being that minimal time period between doses for a vaccine. And the MMR, usually it's for patients who are a little bit older. They were born, say, 57 or later, and they don't have any evidence of a response to this. You may end up giving a couple doses there as well. And then meningococcal are going to be more for patients who are usually microbiologists who are kind of in routine contact with Neisseria in those cases. So again, some of them are very situational based, where if you're dealing with a specific type of strain, if you're a microbiologist or if you're in research. So if, say, for instance, at Nemours, the research pharmacists there, they're actually going to start doing live virus trials, or they're actually using viruses to kind of inject DNA into some of these patients with some of these congenital conditions to treat some of these diseases. But again, that requires this. Obviously, you cannot protect against some of those viruses, but those would be cases where you may need additional vaccines for what you're working with. Okay, so a few vaccines we'll cover in depth. We're not going to cover every single one of them, but just a few that I think are important just to look at in a little bit more detail. First one being the HPV. So why is this one kind of important?
Cervical cancer.
Good, yeah, preventing one of the first, or one of the, several vaccines. Obviously, they can prevent cancer. Things like hepatitis has been around for a while to prevent things like liver cancer and things like that. But this is a good one because it actually prevents a lot of cases of cervical cancer. So we know it's a small virus. There's lots of different varieties that are out there, and so that'll be important when we're looking at the different types of vaccines and what strains are actually going to be targeted against. But not only cervical cancer, they can cause anal cancer as well. Lots of different diseases that maybe these patients may be at risk for. The really kind of the high risk ones end up being 16, 18, 31, and 45, and then some of the other low risk ones you'll see will be covered by some of these vaccines, things like 6 and 11. It's not important to really remember those strains specifically, but we'll look at the differences between the ones that are available. Again, a lot of them are HPV, still the one that causes warts on the hands and feet, but really the ones that can cause issues with either the mucous membranes or the genital epithelium, those are the ones we're going to be focused on. So lots of people end up getting infected every year, and what's the big problem with HPV? Sexually transmitted. Doesn't go away.
You don't know you have it.
Yeah, you don't know you have it, right? So it's very possible for patients to be asymptomatic and spreading it to other people in a lot of cases. They actually, before the vaccine, there's a very, very high prevalence of HPV in patients who had ever been sexually active. Again, very common in men, they just may not be manifesting a lot of the symptoms for it as well. And so they also found that in a lot of cases of cervical cancer, that a lot of these high-risk strains were present there. And so this is one of the things where we looked at and saying, okay, well, 16 and 18 tend to be responsible for a lot of these cases. And then just looking at genital warts in general, 6 and 11, kind of that lower risk, not so much for cancer, but just in general. So it said, well, let's cover for these, because these are the highest risk ones, and hopefully that'll help to deal with a lot of these problems. So that's where the vaccine came from. So again, most are going to be asymptomatic, don't really manifest any actual clinical disease, but things you can see, genital warts, you may see some respiratory effects that can happen here, but then obviously the cervical cancer is a big thing that was initially looked at, but things like anal cancer, vaginal cancer, lots of different cancers that can develop from this. So we'll look at how we can protect against that. All right, so the vaccine that came out was Gardasil. This was originally approved back in 2006 and actually covered against 6, 11, 16, and 18. So the hope was to cover a lot of the most common strains causing both the warts themselves and then also the actual cancer ones. So this would be considered a quadrivalent vaccine because it covered 4 different strains of the virus, right? And so we'd end up using it indicated specifically for prevention of cervical cancer or the precursors, and then just prevention of the warts themselves, okay? And so originally it was actually just approved for females that were age 9 through 26 years of age, okay? So can you use Gardasil in men? Yes, so that has changed recently, right? So usually, because this is a attenuated virus, is going to be given as a 2 or 3 dose series, and so usually give 4 weeks between dose 1 and 2, and then about 12 weeks or so between 2 and 3. We're seeing some of the newer recommendations where they're sometimes giving a 2-dose series. So again, I'm not going to get super specific on the dosing here, just kind of generalities from that standpoint. But some patients may get 2 doses, some may get 3. So there's also a product called Cervarix, which is specifically against this strains 16 and 18, which were specifically the ones causing the cervical cancer. So that's kind of where the brand name comes from. So would you ever use that one in men? No, right, because they don't get cervical cancer because they lack the necessary organs, right? But the newer product is Gardasil 9. And so 9 actually protects against a wider range of strains, and so this is kind of becoming the more predominant one that you're going to be using. So 6, 11, 16, 18, and all these other strains, right? So that way, not only are you getting the cervical cancer ones, you're getting the ones that are also likely to cause the warts, and hopefully protecting against just a wider variety of them. So that way, you're just kind of preventing further spread. So they now recommend routine vaccination for any adolescent aged 11 to 12. Okay, so 11 to 12, get your vaccination whether you're a boy or girl. It can be started as young as 9 years of age, but only under certain circumstances. You guys know when you might do that? Yeah, sexual abuse is a big one, or like rape or something like that. So that would be a case where you actually want to start earlier if you're concerned about that patient having been sexually active, right? So that would be a case you want to do earlier. And then they will, if you don't get it around 11 to 12 years of age, you can get it older. So say between 13 to 26 years of age for females who have not previously been vaccinated. And then they had recommended for males 13 to 21. That range will get bumped up to 26, though, for those that have very high risk for either spreading this or contracting it. Immunocompromised individuals, so you have HIV, or men who have sex with men, they're also at higher risk, especially for things like anal cancers and whatnot. So because of that, they will bump that recommendation from 22 to 26. Okay, so that's where you kind of saw that little bit of difference between the females and the males on that kind of catch-up schedule we were looking at. So, typically you'd like to vaccinate prior to onset of sexual activity, so that way you can prevent as likely of a chance for them getting it as possible.
Why is it contraindicated in over 26-year-olds?
I don't know why it's contraindicated. It's just not recommended. But to my mind, you still think you'd get some benefit from giving even past that. So, Again, that's just what the CDC recommends. I'm not sure clinically what happens with patients. The theory might be like, if you, once you're past that point, the majority of spread that's going to happen or whatever strains you're going to likely contract has already occurred. Maybe hard to say, but I would expect there would still be some benefit to giving it past that, especially when you have a 9-valent kind of vaccine that can protect against so many different strains of it. So who can say? Anyway, if the patient already has an existing infection, obviously the vaccine is not going to be super useful for that, right? So this is only preventing the actual contraction of the disease from happening. It's not going to reverse any effects from that standpoint as well. And again, you can give vaccinations going to be okay for females who are 26 years of age or younger who have, and you can give them any of these cases. So if they have warts already, that's okay because you can still protect against a lot of the more the other strains out there, genital warts, for breastfeeding, the lactating, anything like that. They're okay to go ahead and still receive the vaccine.
So if they're positive for the HPV DNA, doesn't that mean that they're infected?
They're infected, but only with potentially one particular type of strain.
So it protects against the other strains, but not infected.
Exactly. Yep. That's a very good point. Yeah. So you're just protecting against other things that may not have caught yet, or they may be infected with something that is not one of the ones that was actually recovered in the first place. So it's still possible you can get vaccinated and still contract HPV especially if you're only using like the Gardasil or just the Cervarix, especially because again you saw that a lot of the warts are caused by those other strains.
What if someone has gotten the Gardasil, but then they want to protect against these extra strains? Can they get both?
I don't know. That's a very good question. I would imagine you go ahead and, so say like they were like 11 or 12, got the Gardasil, just the 4, and then like the 9-valent came out later on. I'd imagine you just do the full series again. Yep. But again, I'm not an expert on vaccination, so somebody else might have better. There's probably no harm, right? That's kind of the things. You're weighing the benefits versus the risk. I would say there's probably only benefits, very low risk. Okay. This still does not change the recommendation for getting cervical cancer screening, so they would still be recommended because you can still get cervical cancer despite not having HPV, so that would still be recommended for them. Okay. And again, it's always important for providers to do their kind of reiterate the importance of screenings to make sure they can catch those early. Okay. Any questions on that? All right. So again, boys or girls doesn't really matter. Go ahead and get them vaccinated because everyone can get HPV. All right, next is influenza. So this is a very common, this one is just good to cover because it is the most common vaccine patients should be getting, and a lot of people have questions about it, so it's good to have a little bit more info. We obviously know transmission, it's a very contagious disease, goes through airborne transmission, through droplets, all that good stuff, and usually the patients are going to be contagious before they even develop the symptoms, which is always unfortunate because you can be spread around to lots of people. Viral shedding typically is going to be occurring anywhere between 5 days after onset for the adults, a little bit longer for kids, and you can see that for some of the severely immunocompromised patients, so think about like your dialysis patients, your HIV patients, chemo patients, weeks or months they can be still shedding this. So again, just an example of where the peak months kind of pop up for this. Usually around October, November timeframe is when the new version comes out, so when a lot of pharmacies start to get it in stock, and then around the January, February, March timeframe is where you really see the peak effect here. So you see a lot of increased visits to the ER due to respiratory infections and complaints and things like that, and usually a lot of it can be attributed back to this in some cases. But then usually now we're kind of at the tail end of it, so it should be kind of dropping off pretty significantly. So again, this is recommended for all people who are 6 months or older who do not have a contraindication to the vaccine. So everyone, once they're 6 months, should get vaccinated. Again, it's going to be formulated annually. So again, we're just kind of predicting what the most common strains are going to be and trying to protect against those. So if you get the flu vaccine, absolutely can still get the flu. So it's important to educate patients that yes, that's a misnomer. You can absolutely get the flu. A lot of people feel like they have the flu after they get the vaccine. That's just a local reaction, right? Or that's just kind of a systemic reaction to that that injection. Okay, so it's important to kind of know the differences there. So we have the trivalent influenza vaccine. Typically, this contains 2 strains against influenza A and 1 against influenza B, but that quadrivalent is going to be targeting an additional B strain as well. So a couple of different varieties of products we'll have here. So the one we have initially is going to be the inactivated vaccine. So this is the intramuscular form that we can get. So it's Fluzone, Fluvirin, lots of different names for it. Again, different preservatives, different inactive ingredients in those different products. So if they react to one, they may not have a reaction to another one, depending on what their allergies are. Some of them are going to be, they're always going to protect against the same strains regardless, though, so it doesn't matter which product you go with, they're always going to protect against the same ones. But they may be approved for different age groups depending on which one you get. This is an inactivated virus, so this is good for immunocompromised patients, good for anyone at the extremes of age. It's fine for that, but it's intramuscular. And it's going to be approved for anyone 6 months or older. And how many times do you have to get dosed the first time you get it in your child? Twice, yeah. So actually, the first time you get it, so at 6 months, you end up getting 4 weeks later in order to make sure you have a good durable response initially. So this can also be given at the same time with other vaccines, so that's totally okay, because again, you can give 2 lives together at the same time, you give 2 inactivated at the same time, you give live and inactivated at the same time, but again, don't separate out the lives, right? You need to give them 4 weeks apart. Again, anyone less than 9 ends up getting those 2 doses 4 weeks apart there. There is a recombinant one, and this is important for patients who have a severe egg allergy. This one is made without the use of egg proteins, and so this one would be safe for those patients. Okay, so that one would not be commonly stocked in a lot of places, and maybe like a special order kind of thing. So if you know you have a patient with that kind of severe egg allergy, you know they need to be vaccinated, you might order that. And then more commonly, we have the flu mist is going to be the live attenuated influenza vaccine. Right, so this is not good for immunocompromised patients. But it is have the benefit of being intranasal. Also, this is the quadrivalent form, so again, it's going to be protecting against 4 strains there. This is approved for anyone ages 2 to 49. It's not approved for anyone 50 years or older. They recommend going back to the IM form for that, for whatever reason. 50 sounds kind of young to make that cutoff. I'm not sure what the reasoning was there, if that's just the studies they did. It's hard to say, but that's kind of the cutoff. And again, anyone 2 to 8 who's not been previously vaccinated against flu should get those 2 doses. Here they actually recommend anywhere between 6 to 10 weeks apart. But again, if you're getting other live vaccines along with this one, again, space them out by 4 weeks at least. As far as contraindications go to the flu mist, obviously egg proteins involved in the production here, so if they have a severe egg allergy, want to watch out for that. And then for whatever reason, concomitant aspirin use in children and adults if they have, I'm not really sure the reason for this contraindication, but they recommend not having concurrent aspirin use when receiving this one. And then obviously it's not recommended for anyone who should not receive live vaccines, so pregnant women, immunocompromised, they have an egg allergy, they have, if they're 2 to 4 years old and they have an asthma or a wheezing episode, this may potentially exacerbate that if they have an allergic reaction, so we want to watch out for that. Or any antivirals in 48 hours. Why do you think that's the case? Yeah, you'd be fighting off the vaccine that you're trying to have a response to, because this is a live attenuated vaccine, so it's live attenuated virus, so you don't want to end up inhibiting that by giving antivirals.
Wouldn't the aspirin use be for Rye syndrome?
Right, but that's kind of a general recommendation just for people who are post-viral anyway, in that kind of age range. But again, they still recommend it. Well, I mean, it's probably something linked back to that, but I'm just not sure of an increased risk. Because people usually don't get the flu and then get the vaccine. Like, hopefully you're getting the vaccine before you ever get the flu in the first place, you know? So it may just kind of a liability thing. Who's to say? Okay, then we have rabies. Anyone ever had rabies before? No, because you'd be dead. Just kidding. Yeah, so this has basically there's like 2 cases of people ever survived. It's probably a little bit higher than that now, but actual true blue cases of rabies is almost universally fatal in a lot of cases. If you ever read the case reports of the people that survived, it's very, very interesting kind of what they put those people through. Hypothermia, put them on a pentobarb coma, and just kind of try to let their body kind of ride it out, and it's very, very dramatic when they actually survive. So it's very kind of interesting to read that. Where do you get rabies from? Animals. What type of animals? Bats could be one. Raccoons. Skunks. Squirrels can be another one. How about hamsters?
Cherry.
Are you known to bite? Occasionally. The mood strikes you. Okay. So anyway, so this is an RNA virus, so it's a little bit different than what we're used to dealing with. But if you look at the actual reports of death, obviously not a ton here in the U.S., right? Usually we have pretty good treatment and prevention of rabies. This is usually in other countries where you see a lot more deaths associated with it. There's really interesting videos if you ever look at people who are kind of more further progressed in their cases of rabies to see kind of the different symptoms they manifest. We may have 3 cases per year in the U.S. In the most cases, they do not do well if they end up kind of progressing. And it's actually found everywhere in the U.S. except for Hawaii. So if you ever want to get away from rabies, if you're really profoundly scared of it, go to Hawaii. This is almost always going to be occurring through a bite. Rarely can you have things like aerosolization, but potentially you could have transplantation of it. So if you were to donate an organ and the patient had rabies, you didn't know about it, give it to someone else, they could actually develop rabies. Okay, that's not a very common occurrence, but that's one of the things you screen for, so make sure they don't have rabies beforehand. Dogs actually end up accounting for a large percentage of these in other developing countries. So just be aware the dogs are a big one. Here in the U.S., obviously dogs are not as big of a case, but certainly you can see bats, raccoons, skunks, foxes, all can be harbingers for rabies. So usually what you end up seeing is that the bite will happen in kind of a peripheral wound, usually the hands or feet, somewhere like that. It will actually travel up the dorsal root ganglia up to the brain where it has this kind of final effects here, but can also get to the CNS. From the CNS, it will go to the heart, skin, salivary glands. That's where you can see some of the other symptoms manifesting. And then the factors that affect your risk for it include things like how large of a bite it was. You know, obviously, if they are inoculating you with a larger amount of the virus, you're going to have a much harder, much more to fight off in that situation. Also, the site innervation, or how close it is to the CNS, can affect that as well. So if it has a longer distance to travel, it takes longer for it to actually to affect the patient. So that can be kind of interesting. And just their host immunity. In some cases, you may be able to fight this off on your own without any kind of help. Lots of different kind of interesting manifestations here. So they have the encephalopathic, kind of the furious symptoms that happen about 80% of cases. They have the hydrophobia and aerophobia. So you actually like kind of puff them with air, and they would kind of kind of freak out with that. You also have the paralytic symptoms as well, so it kind of mimics kind of like a Guillain-Barré kind of picture. And so you kind of have this 5 stages, because it can take some time for it to really incubate. So you have the kind of incubation period, it's prodrome, and then finally get to this acute neurologic syndromes, coma, and finally death. So again, most patients, once they kind of get progressed to the point where they're having the neurologic syndromes, there's not a lot you can do for them. They're just going to go on their way. And again, it can take quite some time for it to incubate, 1 to 3 months on average. This is why you may have an animal that may bite and may not really be manifesting any symptoms, but can still be transmitting the disease. So how can we prevent this if you have a bite? Because this is a very common thing you are concerned about when you have an animal bite coming into say the ER. Very important to do good wound care. Obviously, this is going to be the most important thing you can do, is thoroughly wash with soap and water. Some people use a virucidal agent like povidone iodine, so that can be useful there. And it helps to reduce likelihood for pretty significantly by about 90% or so. And then also the question is going to be for antibiotics and then tetanus prophylaxis. So very frequently, as I was just mentioning it before class started, you'll have cases where kids will come into the ER. The dogs were vaccinated against rabies. The kid's never been vaccinated one day in his life. It's kind of interesting where the priorities are going there. But anyway, so again, if they're not up to date on tetanus, you can get them a dose there. Or if they, if it's a kid and they've been getting their natural doses of DTaP and Tdap and all of that, like you don't actually have to do anything. They're well protected at that point. Obviously, antibiotics are going to be more kind of specific to the animal you're dealing with. So things like ampicillin, sulbactam can be used in a lot of cases for some of these animal bites. Augmentin orally, usually worried about things like Pasteurella and anaerobic bacteria, things like that. But really, washing off the site is usually one of the most important things. So, but we do have, if you had really big concern, and so when might you have concerns that the patient may have been exposed? What are some things in the history?
There's a dead bat in the room.
There's a dead bat in the room, right? Or if you just wake up and there's like a bat in the room, which that's terrifying, right?
Patient's frothing at the mouth.
Yeah, the patient's frothing at the mouth. You're too late to do anything. But certainly, if you the bat was just like or the dog or something. Usually, you don't see them that classically presenting, right? Have you guys ever seen the movie The Great Outdoors? Dan Aykroyd and Chevy Chase, and they're chasing the bat out, and they have a little hockey gear. Yeah. Anyway, watch that movie; it's actually pretty good. But right, so if they see like a bat in the room, the other thing is if you don't have access to the animal that bit them anymore, right? So if it was a wild animal or if it was a dog, you don't have access to the records, right? Obviously, wild animals are not going to have any records, but if it's like a dog, like a neighbor's dog that bit them, if they can provide records that say yes, they've been immunized against rabies, you really don't have to worry about it, right? It's these cases where it's an unknown, especially with a high-risk animal, that you worry about vaccinating and giving the immune globulin for these patients. So again, most of the time, dogs here, not going to be a problem because most of them have been vaccinated. Most of them are domesticated for the most part. But say if you go to other countries and other places, you may find if they have kind of rampant wild dogs running around, like they're much more likely to have it. So think about kind of your environment. But if we do have concern that they may develop rabies, we give them the rabies immune globulin, right? And so this is providing active or passive immunity. Right, this is passive immunity because this is going to be just a straight immune globulin against the actual virus itself. You can see here where you dose this in units, so usually 20 international units per kilogram, and this is what's preferred in the U.S. This rabies immune globulin. A couple different varieties. You may see Imagam, Hyperrab. Those are all different brand names for the same thing. Basically, this is nice because it provides immediate neutralization for the virus. And so what's interesting is you actually administer this around the bite site. So you basically drop your dose, and you can aspirate this into kind of the space around the bite. And then if you have anything left over, you'd administer this intramuscularly, right? So you try to get as much as you can, so especially if it's like a large bite, for it's like, say it's like a bite to the thigh or something, you can usually inject all of that right around the site. And again, it's nice because it prevents any of the virus. It's neutralized. It can't travel up the nerves to get to the brain. The other thing you do at that time point as well is to give the rabies vaccine. So again, we will sometimes give this for patients who are at high risk for being in contact with rabies. So things like animal control personnel, things like that. But it's nice here is that once you're vaccinated, you have a pretty good durable response to rabies. And so we have a couple of different varieties here. So you have one that's a human diploid cell vaccine, or HDCV. So you may see Imavax. And there's one called Rabivert, which is actually made from purified chicken embryo cell vaccine. Where they figured out that you can use chicken embryos, who knows, but basically Rabivert is going to be the other brand. It doesn't really matter which one you use, they're kind of synonymous. And so these end up getting administered intramuscularly. There's going to be pre-exposure guidelines, and there's post-exposure as well. So pre-exposure being those who are at high risk for being exposed will get vaccinated beforehand, and then post-exposure obviously being after the bites actually occurred. Again, do not administer in the gluteal area. The deltoid is going to be preferred here. Usually if you need to give any of the IG along with the vaccine at the same time, you give them in different deltoids. You don't want to inject them in the same spot. So again, like post-exposure wise, we would end up giving 1 ml in the deltoid at day 0, and then you actually have the patient usually end up following up the Department of Health. That's usually the primary people who kind of monitor that and will follow up with the patient. So again, at day 7, 21, 28, and then potentially if they have been previously exposed, or they've previously got vaccinated, you can give them a booster on the day of the bite that actually occurred. But that's usually a small subset of patients who have been previously vaccinated. So there's always a question of like, should I use the rabies immune globulin? Should I start the vaccination process up now? And there's nice algorithms that are available and kind of walks you through the process of deciding, do they need any post-exposure prophylaxis? So for example, if you're running through this, let's say, okay, was it a mammal? So no fish bites, anything like that. Animal with fur, so really delineate that for some people. Bite the patient. Say no, it was a snake. They don't need any rabies prophylaxis. No pit vipers with frothing mouths, right? Did they actually have an open wound? Has there actually been a puncture that's occurred? All these different questions. Did the patient have direct contact with a bat? They can rule it out. If not, they don't really need post-exposure prophylaxis. Risk is very, very low. If they're yes, then you can look to see, was it any kind of these high or low-risk animals? So high-risk animals already mentioned. I think things like woodchucks, coyotes. I don't know how many woodchucks you see here in Florida, but certainly skunks, raccoons, bats, anything like that could be a high-risk animal. And then if they are available to test, then if you can rule it out, because you can actually hold off on the vaccine, you don't have to give that very initially, but potentially you can hold off, start them on the immune globulin, and then get the animal to test it, and then potentially start the vaccine later. But if you are not available to test it, so if the bat flew off, then you go ahead and give them the prophylaxis anyway. Lower risk animals, things like squirrels, chipmunks, things like that. Typically, no post-exposure prophylaxis. Dogs, cats, again, typically these are mostly domesticated. Very unlikely for them to actually have any rabies. We have to go through and see, okay, is it available for quarantine? Because kind of the two ways you test for rabies are what? Yeah, so you either do a quarantine where you look to see if they develop symptoms, or you hopefully have the animal either it's dead or you kill it and then you do like a brain tissue sample. That's usually the most common way to do it. So obviously if it's, your dog Bingo, you don't want to necessarily kill him to see if he has rabies or not. So usually quarantine's the thing for kind of domesticated animals. Again, looking at things like rabbits or gerbils, very, very low risk, especially if it's just an indoor pet. You don't need it there. So look this up if you had a patient. If you're like, do they need immune globulin? Do they need the vaccine? Just kind of walk through it and see, like, okay, are they really high risk? Most of the time, no, they don't need it, right? Most of the time, they're very low risk for actually developing rabies, at least here in the U.S. Okay, next we'll have tetanus. So again, this is an exotoxin of the Clostridium tetani. This one is really the only vaccine preventable disease. It's not really contagious. Most of the tetanus we see comes from the environment. So again, you think about things like wounds. A lot of trauma victims can potentially develop like wound tetanus and things like that. And so the way that tetanus works specifically, is different than something like botulism. So it actually works by preventing the release of inhibitory neurotransmitters. So here you end up seeing a blockade of things like glycine and GABA from being released, so you end up developing tetany, right? So you have overactivation of the muscle tissue, have the spasming that's occurring here. Then you have some other problems that develop like PE, dysregulation of the autonomic nervous system, etc. So obviously we'd like to prevent this if we can, which hopefully they've been vaccinated previously, but if not, what do we give them? You give them TIG, you give them tetanus immune globulin, right? So yeah, this is another one we can actually provide passive immunity for the patient if they are at high risk. So certainly we can use the tetanus toxoid. That is going to be preferred. This one's actually just absorbed onto something like aluminum hydroxide, different salts like that, to give us a little bit better chance to actually hook onto it and produce some immunity against it. Again, it's nice because it provides protection at least for 10 years for fully immunized individual. Usually you'll see it used either TD being given for most patients unless they've had a Tdap at some point in their life after that. But again, if you're not sure, you can go ahead and just use Tdap. A lot of times we'll have kids that coming in that have never been vaccinated before for wounds and things like that. We'll actually give them DTaP to get them started if they're less than 7 years old. That should actually be a big T in the DTaP. And then obviously the AP is it's acellular pertussis, for that one. And then for the tetanus immune globulin, you can give that if the patient had been previously unvaccinated and for more serious wounds. So this one we do not give very frequently, but it's a very serious wound, no vaccinations, you can give the immune globulin for that kind of active immunity, or give the passive immunity very, very quickly. So again, you kind of work down through an algorithm to deciding, okay, well, is it a clean minor wound? Now you probably don't need to give them any kind of immune globulin, but certainly you can get them up to date on their tetanus, right? If it is anyone else, if they're unvaccinated, if it's a very serious wound, certainly you can consider giving the tetanus immune globulin along with the vaccine to get them started on that. Okay. And then finally, just kind of in general, we'll talk about immune globulin by itself. So this is really the IgG that we're giving. So this is actually derived from donor plasma. So it's actually been purified. They kill off any of the pathogens that are in there. They use kind of ethanol cold distillation, where they actually will kill off things like HIV and hepatitis and other kind of products. And what you're left with is just this nice amalgam of all these IgG from different people. So it has a wide variety of activity against lots of different pathogens because, again, your immunity may be different from your immunity, and so if you combine them all together, you get this kind of super goo of immunity, right, that you can inject into a patient. So it has a nice long half-life, so it can usually have anywhere between 18 to 32 days because it's a protein, sticks around for a while, and you can use it for lots of different things. So if you have a primary immunodeficiency, we will sometimes use it for ITP, or idiopathic thrombocytopenic purpura. We can actually use that to help prevent some of that hemolysis happening there. Kawasaki's disease, and then we use it for a lot of different off-label uses. So if you ever work for like a neurologist, or if you work with like an infectious disease doc, or if you work with pretty much anyone, if you're not sure what to do next, go to immune globulin, right? That's what it seems like, at least from the pharmacy side. It usually seems like if you're grasping at straws, IgG is the way to go. But lots of off-label uses, lots of kind of questionable data whether or not that's going to be really effective for what you're trying it for. Usually the adverse effects you're going to see with this is that because you're injecting other people's protein into a patient, sensitization and anaphylactic reactions are possible. Okay, so you have to make sure you inject this kind of slowly to help deal with these, because they're going to get chills, nausea, vomiting associated with it just due to that kind of local immune reaction. But some people may have more severe reactions, so keep your anaphylaxis kits on hand, right? It's also very, very expensive. So, for a patient, we may dose them, say, 1 gram per kilogram. It's about $200 per gram. So this is why we like to keep it kind of hold on to it until we're really sure like there's a really good case for using it. So for instance, for ITP, for some of our patients, if the hemonc doc calls up and says, hey, I got this kid with ITP, I want to use immune globulin for them. Because it's more expensive, right? Well, is there anything we can use that's cheaper that may be as effective that you can use as a kind of first line agent? So there's another drug we'll talk about called Winrow. Sometimes we'll use that first, and if that doesn't work, then we'll move on to the immune globulin. So we try to keep kind of a tight control on this one because otherwise use gets pretty rampant. If one doc says, hey, they let me use it this one time, then everyone else tries to use it too. So you can kind of have this like kind of jump-on effect for everyone trying to use it at the same time, and it gets pretty expensive. There's lots of different brands that are available, so they have things like Gamma Guard or Privigen. Again, some people may have a reaction to one product and then not to another, so you just kind of try and see what they respond well to. The other thing you have to worry about is religious groups, specifically Jehovah's Witnesses. They do not like to receive foreign blood or foreign blood products, and so because this is pulled from people, it's not like it's a recombinant product or anything like that. They will not receive this, so you may need to consider that and have a discussion with your patient. Okay, and then finally, we have the Rho-D immune globulin, or Winro, or Rogam. You guys know when you use this most commonly? Yeah, pregnancy is going to be the big one, right? So this is good for patients who are Rho-D negative and maybe exposed to Rho-D positive erythrocytes, right? So say if like dad's Rho positive and ends up donating that to mom, and she's Rho negative, she needs some coverage for that, because otherwise she'll get exposed and may have this hemolytic disease that can occur there. So we want to prevent that if possible. So this helps by giving the immune globulin, provides that kind of nice passive immunity, will reduce that antibody formation that occurs there. But again, you need to know mom's Rho-D status. So if she is positive, they don't really need Rogam, right? Because they're already not going to have a reaction to that. Or if they already have anti-Rho antibodies, then they would also not have an issue with that as well. Okay, so any questions on immunizations? Okay, so you guys are all going to go out there and get immunized right now. It doesn't matter if you've already received it, just get something. Okay, if not, I'll see you guys on Thursday.